My name is Ruth Werner. I actually know most of you. And if I don't, hi, I'm Ruth. This is and I will let my partner introduce herself. But we want to welcome you to this discussion, and we want to really thank you for giving up a sunny afternoon in Tucson, where there's a pool about 500 steps away, to come and listen to this presentation. This is what we're going to be talking to you about today, is what we learned, we being the Massage Therapy Foundation, what we learned when we asked a very big and very important question. And the answers are nuanced and a little bit complex, so it's not a yes or no kind of question. So we're here to kind of walk us through this project with the hope and goal of giving you some ideas about ways you might be able to apply this or use this or have it flavor your communications with other people, other massage therapists, other medical professionals, special client groups, whatever. There are lots of ways to use this kind of information. But what we're going to be presenting to you is the results of the largest meta-analysis and systematic review about massage therapy in the context of pain ever done, ever. So it's kind of exciting.
It's super exciting.
It's super exciting. So how about if you...
Sure. I'm Jerrilyn Cambron. I'm the current president of the Massage Therapy Foundation. It was very hard to follow in someone's shoes as the immediate past president, but I absolutely love it. So for 25 years I was a researcher, and just this past September I became an administrator overseeing the College of Allied Health Sciences and Distance Education at the National University of Health Sciences. And what that means is I oversee the massage program. So I am a massage therapist, and I oversee a massage program, which is so super exciting. So when I am here at the Alliance, it's much more meaningful to me. Not that it wasn't important before, but as a researcher coming to like a schools event, it's a little bit of a different flavor than now being an administrator at a schools event. So Ruth and I have talked about these articles quite a bit. And so we
this
like
is our fourth time I counted.
Yeah, we like to just go back and forth because we're viewing things very differently. You know, looking at the same thing, and we don't really have differences of opinion. But because we're viewing them differently, we have different types of input. So we really enjoy doing this together. We're both very laid back. If you have questions, feel free to just shut them out and ask. Neither of us try to speak at a level that just nobody understands. So if there's any terms that we do use that you're not familiar with or you'd like to get clarification on, please feel free to just ask.
Given that, I'd like to ask a question that I didn't already know I was going to ask. How many people in here feel that they could clearly and successfully define the difference between a meta-analysis and a systematic review? Good. Excellent. I think maybe we should start with that.
Sure. So there's a lot of different types of research out there in the world. Have all of you read research at all? Like gone on PubMed and searched and found a few articles? So when researchers take research and kind of push it all together, it's a review article. Now with systematic reviews, it's called that because it's a very systematic process. The researchers in that article, that review article, will tell you, here's our search string that we used in PubMed. Here's how we evaluated, are these quality articles or not? Here's how we collapsed the, looked at all the pieces of data. So a systematic review is a review that's very, very systematic methods in figuring out how to find the articles. So if you follow those methods, you find exactly the same articles. So sometimes we'll read narrative reviews, and they look great, and there's a lot of information, but it's like, how did they choose these articles? Okay, that's not as strong as a systematic review. A narrative review might give you great information, but it also might be really biased because you don't know how did they decide which articles get included and which articles don't. In a systematic review, they tell you exactly. These articles, they have to be clinical trials, they have to be adults, they have to have these parameters, they'll tell you everything about it.
What I want to add to this, to just be clear, because I didn't know this right off the bat, a systematic review is not an experiment. It's a collection of information about other people's experiments. So it's taking a bunch of things that have some things in common to see what are the apples that we can compare to apples. And then you do it very carefully and systematically. It's a systematic review.
Yeah, so if you take a systematic review and there's common types of data, like let's say we're looking at pain studies and clinical trials and they're all doing visual analog skills. So now what researchers can do is from every clinical trial, pull that data out and do one big analysis with all of those pieces of data. And guess what that's called? A meta-analysis. That's why it's a meta, because it's like a big analysis.
Beyond.
So sometimes we can't, because like if we look at, let's say, quality of pain, is it sharp, stabbing, dull, achy, you can't really analyze, you can't shove all that together. Or if we look at activities of daily living, there's so many different outcome measures out there, and you can't really analyze them all together. And so then we have to stay at the level of a systematic review, because we can't do a meta-analysis, because then we're looking at apples and oranges. So systematic review is great, and if they can pull data out and collapse it, it then turns into a meta-analysis. So meta-analysis has all the systematic review components, it just then also has an analysis.
Which usually is statistical analysis. Statistical. We're not doing statistics.
We're not doing statistics.
Oh, I know. We're going to learn a little bit about something I'm really excited
Don't
to.
promise it.
So, this is me, right?
Yes.
Yeah, this is me. Okay, good.
Well, that's
better
not
get
you.
good. Well done. So,
Ruth, before you go,
Yes.
are these slides in handout form, as PDF?
I don't know why they're not on the Google. We gave them.
Because I didn't see. I was told. Yeah.
Oh, okay.
Yeah. These afternoon classes.
Oh, they'll get up? Okay, so
it
we
hasn't
gave
been
that.
updated yet, but it should be on the Hoover app.
And we also gave the actual articles we're talking about, so it all should be there.
Okay, great.
Good, thanks.
If it doesn't make it, just email us.
Good. Good. So the first thing I'm going to say about the next couple of slides, which has some statistics about pain, is that these are already dated. And if you follow anything in the news, you know that the problem of chronic pain and opioid addiction and the cost in life and money and heartache is even bigger than these pictures, because I think some of the most recent data that we used as we were compiling our project dates from 2014. Okay? So even way back in 2014, chronic pain and pain management was already being discussed as a global health problem. And we recognized that 1 in 5 people reported pain on a regular basis, and a lot of those people, 1 in 10, report with chronic pain, which basically means a situation that lasts more than, what is it, like 6 weeks? 3 months. 3 months, thank you very much. It was interesting, and as we were laying out the parameters of this project, we suggested maybe we want to just look at acute pain, or maybe we want to just look at chronic pain, and one of the people at the table said you can't do that because people go back and forth. And so we need to look at the bigger picture.
And sometimes chronic is 6 weeks, or 3, it depends on which definition you're looking at.
Yeah,
So,
and we'll share all the definitions that we started.
3 months is usually.
You're quite right. All right, so do we need to really make an argument for why studying pain is important? Probably not. In a research article, you begin by making the argument for why your question is important. So here it is, 100 million people with chronic pain, 635 billion in annual costs. This is all from the World Health Organization and the Institute of Medicine. This is a chart about drug overdoses involving opioids. That's the solid line on the top. And again, this dates from 2014. It's much higher now. Okay? And I will share, she's not in the room, so I had a lovely conversation with one of our attendees, Robin Anderson, who works in Baltimore and working with interprofessional education. She runs a massage school, and she was attending a meeting where there were a lot of other medical professionals, and she's the only one who stood up as they were introducing themselves and said, I'm here and I'm representing massage therapy. And the room full of PTs and pharmacologists and MDs all went, ooh. Maybe out of touch hunger, right? But also because we are desperate for non-pharmacological interventions for pain management. So we were, possibly a year or two ahead of the curve with creating this project, but it's going to stay current and valuable for us for a long time. So some of this seems so intuitive and so obvious that it's hard to understand why it needs to be said out loud. But what the medical community, the conventional medical community, is now more openly and more enthusiastically embracing is this idea that pain is not just related to a mechanical problem, that pain is multidimensional. And it's not just related to tissue damage, but it's related to how we respond to that tissue damage and how important is it to us in the rest of our life, and what our social systems are like, and what our spiritual systems are like, right? And so we are recognizing that pain is complex and multidimensional. Approaches must address the whole person. Anyone here old enough to remember holistic medicine? Right? Everything old is new again. Back. And what we find, and again, and there's data to back this up, is that when people attempt to treat pain without addressing all of the components that contribute to pain as not as a sensation, but as a response to a sensation. If we don't treat all of the components, we don't address, and it's not, I always go to my foot because I'm having a chronic foot problem, but if we don't address how much this impacts a person's quality of life, as well as whatever might mechanically be happening, we probably are not going to have a successful outcome or a long-lasting outcome. Go ahead.
I'm sorry, I might have missed this. Where does this slide come from? Who's now figuring out that it's multidimensional?
This is from the Institute of Medicine.
Oh, great.
Well, that reference comes, the failure to adequately treat escalates other problems, comes from the Institute of Medicine.
So they don't necessarily define the whole person as mental, physical, emotional.
We're going to, not necessarily. We're going to actually share with you our definition of pain, the definition of pain that we used, which also comes from the Institute of Medicine. Okay? Good, thank you, great question. Anything else before we move on? So, does anyone know, there's another term that's becoming very, very popular, at least in the circles I hang around with. Yes?
I'm so sorry to interrupt you. Can you kind of backtrack for me? I'm sort of a picture person. So did you two do the meta-analyses that you're reporting?
We're going to get there. We were involved. We helped.
I know. I have to wait for you to tell me the picture.
Yeah, we helped.
It was a group of people in coming at it from different directions.
Yeah. Good. I know now I'm lost. Oh,
The biosocial, psychosocial model.
thank you very much. That's where I was going. The biopsychosocial model of pain management, or of health management, speaks to all of these aspects. And so, again, we did this study before BSM was sort of making its way into BSP, sorry, I did that wrong, BPS, biopsychosocial models of pain management was sort of filtering into the massage therapy community. This study was already out. We're so ahead of the curve. Okay, anything else before we move on? Good. So, the Massage Therapy Foundation, did a little landscape check. We had the opportunity, for reasons that Jerrilyn will talk about in a minute, to ask a big important question. And we had some resources and some connections to ask that big important question with people who could really help us figure out some of the answers. So the question that we asked was this: what is the state of the science regarding the impact of massage therapy for populations living with pain? And that was sort of the starting place. Our final research question is slightly different from this, but this was our question when we were surveying the landscape. We began this in 2012. The general question was, where are we? If we collected all of the science and we smushed it all together, what would we learn about massage therapy and its impact for populations living with pain? Good. And now I think it's yours.
So when Ruth says that the foundation talked about this, this was in Board of Trustees meetings. We're always looking for how can we help impact our profession? How can we help pull science together or get new research out there and make sure people know what's going on out there? And we felt like, you know, when we talk about here's the state of the science, we didn't really have that. And so we thought, you know, really, we need to be doing that. And that's within our mission. And so we were really excited to get this going. And at the time that this happened, Diana Thompson, who at the time was our president, she went to a meeting at the Samuele Institute and learned about systematic reviews and meta-analyses. And then Ruth took over as president, and you know the board was still talking, what should we do, what should we do? And we ended up getting a $50,000 grant from AMTA, and they said, but we want it just to go to research. And we're like, oh, we have a great thing. We got it ready, you know, this is what we want to do. Now you might think, well, this is a review article, why do you need any money for, you know, to read articles? Well, what we wanted to do was let others do the review. Because we didn't want to interject our bias, and then when people read it, they go, well, massage therapists wrote that. Of course they're going to say this. And so we went to people called the Samuele Institute, who really focus on whole health, and they're very interested in lots of different integrative medicine, and said, and their main thing is doing systematic reviews and meta-analyses. And this is the group that Diana had seen, and we're like, will you help us? And
They have a method for doing this.
Yeah, this is like their thing. This is what they do for people. And we said, you know, will you help us with this? And they're like, well, we would love to. So when the question was, you know, who actually did it, it wasn't Ruth and I, but there were different work groups. You know, there was one big one, but we represented different things. And the people who actually pulled the data, analyzed the data, was not us, so that it was not biased. And we'll go through how that actually worked. So this is just kind of a shortcut preview as to all of the different steps. Now you might think, well, okay, a review article, don't we just read the articles and then talk about what it says? Well, no, because first we have to say, who do we need on our work group? And what is the question we're asking? And then search the literature and look at which articles are we including and which are we excluding, and that's the systematic review part that we were just talking about. And then they have to actually review the literature and look at quality and pull data out, and we'll get to that. And then do the synthesizing data and the meta-analysis and pull in all the statisticians. So this actually isn't that straightforward. I mean, again, you might think, well, you just pull some articles and read them. Well, there's a really big process. So again,
Do it well.
systematic reviews are really challenging to do. It is quite the process, and we were very excited to be part of it.
Okay, good. So you've asked, you know, were we involved? Did we do it? We helped. And so among the first steps here, there's a familiar face.
That's Pete.
There's a familiar face.
Jan.
There's a familiar face. So we assembled the work group, and the work group was composed of three different stakeholders, massage therapy experts. So we really worked hard to gather some subject matter experts about massage therapy. It was Jerrilyn and me, Jan Schwartz, Pete Wittridge, and Chris Deary, who's now on the National Board of Directors of the AMTA. Okay? Those are our massage experts. We wanted a group of experts about pain and pain science. And so this would be Dr. Buchenmeyer, who's an anesthesiologist and acupuncturist. His wife is a massage therapist, so she came along too. Dr. Pasquia was the head of orthopedics at Walter Reed. Dr. Schoonmaker was the the Surgeon General, retired of the U.S. Army. He was very committed to making this go. And then we wanted some people who were experts at how to do systematic reviews and meta-analyses, and so that's the review team supplied by the Samuele Institute.
So when we as massage therapists sat at the table with these folks, we're like, what are they going to think? Are they going to like us? You know, what's going to happen? What if, the literature embarrasses us? Because I don't know if you've ever heard this, but a lot of people say, oh, it's not very good, and we don't publish good good papers, and they're not high quality. And so we were worried. But they were very serious about that, because especially in the military, they don't want this opioid crisis. They're trying to figure out how do we prevent that. Now that's why Dr. Buckenmeyer became an acupuncturist. He was an anesthesiologist, but he wanted an alternative. So he then became an acupuncturist, so, on the field, he could do acupuncture instead of, here's some pills, put them in your pocket and take one every 4 hours. No, he was trying to find other ways. So they were actually very excited about this whole process, as were we.
And as excited about the outcome.
Which one is Dr. Buckenmeyer?
Oh, he's in uniform.
Yeah,
Colonel.
yeah.
Colonel Trick Buckenmeyer
Yes.
III.
That's what I figured.
Yeah, he spoke. If anyone was at the Seattle meeting, he was one of our keynote speakers, and he's very earthy and he's hilarious.
Oh, he's speaking at AMTA National this year, too.
Oh, is he really?
Yeah.
That's awesome.
He told us to get over ourselves.
Yeah.
And I believe there was a camel head in the butt.
Yeah, there was a camel
Yes.
under the tent analogy.
That's right.
He was saying that, and he speaks in military terms, but he said that if, as massage therapists, if we thought of ourselves as a camel and we just got our nose under the tent, we could get in. And that we need to get over ourselves and stop using these terms that don't really make a lot of sense to the medical community and start using regular medical terms. And, even if we believe in things like energy therapy and things like that, the military doesn't want to hear about it. That's not their thing. And so we need to speak their language. So that's when he's like, just get the nose under the tent. So.
Good. So at the very first meeting of the working group, our first job was defining the research question. And I'm going to go ahead and tell that story. So we were struggling and struggling, because if you've ever done, anyone here ever worked on a research project, done a case report or anything, you know that the hardest step is actually defining your question. So it was something that we really struggled with and we wanted to get just right. And at one point, the word, something about the impact of massage therapy on functioning for those suffering pain was the title. That was being promoted by Dr. Schoonmaker, the Surgeon General of the U.S. Army, and I said, absolutely not. We are not having the word sufferer in this title. It's an unhelpful word, and I won. Yeah, I know. It was a very exciting moment. I've been living on that moment for a long time. So I'd actually like to take this apart a little bit, because there's a variable in this research question that is absolutely vital to understand. So it's, what's the state of the science regarding the impact of massage therapy, so far that's what we've already talked about, on function for those experiencing pain. And we chose to do it this way because if you look at pain and you don't look at function, you're not getting the whole picture. And what we see very often is that people who go through something and they have some relief in their pain, then their functional level goes up until they're back in pain again, right? And so if we don't address both of those issues in our research question, we're going to be missing out on some really important information. What it led to was a much, much more difficult project. And that's why the answer to this question is not yes or no, or good or bad. The answers to this question is, it depends on what part of the question we're looking at. Go ahead, John.
So this probably makes it even more complicated, but if we're looking at, the question seems to me like it's not looking at both sides. It's not looking at the experience of being in the function. It's just looking at the function, right? So I'd be curious what the science is regarding the impact of massage therapy on the experience and function of those experiencing pain. But that would add an exponential level.
Yet another layer.
Right.
I mean, some of that gets captured in the data, but what we were really looking for was outcomes. And the outcomes that we were most interested in was function rather than pain, because that just seemed like the better long-term outcome.
Is it function more measurable? If
objectively?
Actually, no.
It isn't?
It turns out it's not.
Yeah.
Because the word function is pretty vague.
Okay.
And, you know, in terms of asking questions about pain, there's a finite number of ways that we ask questions about pain, like on a visual analog scale, or a Likert scale, or a descriptive, you know, some agreed upon descriptive language. But there's
Those are
an
functional.
infinite numbers of ways to ask about function.
Yeah.
So it's turned out
You
not
had
to
to
be.
codify that and standardize that. Yeah.
And unless you have everybody using the same language, or you're talking about apples rather than avocados, you know, then it's hard to compare results, as we will see.
Has anyone ever heard of a PICO question? Yeah, it's a way to search. If you're in PubMed and you're not really getting what you're looking for, you should think of PICO. It's what they teach in medical schools. And what that stands for is, what population are you interested in? What intervention is the I? What comparison? And then, which is the C, and then the O is what outcomes. And so what you can do is, if you can define those 4 things, and sometimes there's an S on the end, which is what type of study design. So it's patient, intervention, co-intervention, outcome, study design. If you can, you know, come up with some sense of what you're looking for with any of those, you can start putting those into your search bar and maybe getting something more specific as to what you want. So when we're looking to search for articles, we went through this exercise of, well, let's go through a PICO of what are we really interested in. So we started out with the patient. Patients experiencing pain. Well, that sounds pretty straightforward. Well, what do we mean by patients, and what do we mean by pain, and you know, how do we pick which ones just in terms of the population? Are we okay with kids? Are we okay with infants? Can you tell if infants have pain? Are we okay with people with broken legs, or are we only looking at surgical? You know, what are we looking for? And we're like, oh my gosh, this is harder already. So, you know, this is what we ended up coming up with as our definition for pain.
Well, this is the IOM, this is the Institute of Medicine definition, and we agreed around the table that, okay, this is the way we will define pain for this exercise.
And that's, you know, when we come to these conclusions, it's always better to come up with something that's predefined. And so we were looking at different definitions of pain, and it was such an interesting conversation about, we came to the table thinking chronic pain.
Right.
And they talked us out of it. The pain experts talked us out of it. They said, no, you need to look at all pain. We're like, oh, okay. Sure. Yeah. So that was our first taste of the PICOs. Is there a question? They then said, okay, well, define for us, what is massage therapy? Do you think that was easy? Oh my gosh.
And the other thing, and we were doing this before the brilliant article by Dr. Kennedy that helped provide some really elegant definitions for massage versus massage therapy versus massage therapy practice. So we scrambled.
We looked at many different definitions that were already out there. So ELAP was out there. The body of knowledge, empty body of knowledge was already out there. We looked at the different main organizations within the profession, and we were trying to come to some consensus. And, you know, really, which part of massage therapy are we okay with? Because there's some things that are a little different. Are we okay with shiatsu? You know, where do we draw the line? And this is what we ended up coming up with. And it's the systematic manipulation of soft tissue with the hands that positively affects and promotes healing, reduces stress, enhances muscle relaxation, improves local circulation, and creates a sense of well-being. And they said, well, what terms do you think you might see? Like, what should we search on? So we just started naming things off. And so this is what they use to search. Because sometimes in massage articles, they don't say, we did massage. They call it something else. And so we wanted to make sure we had them capture all of the articles. And again, we weren't the ones searching, so we weren't the ones to say, oh yeah, that counts, that doesn't. We had to tell them. And they did keep coming back to us and say, now is this massage, do you think that fits? And we're like, well, let's talk amongst ourselves first.
No, it's not a fit. Prostate massage,
Right, right.
Cardiac massage, not in our thing.
Right, and so we really had to try and help them, and they would send us lists of just populations, or massage terms. This is how they described it in the article. Do you think this fits or not? And as subject matter experts, we, along with the other three, would get together and talk and say, are we all good with this or are we not good with this? And we had to come up with yes, no. So that's how they searched for the massage. And then comparison control. In clinical trials, there's different ways to have a comparison group. They can compare it to a sham. What's a sham? Made up, like a fake thing, a placebo, something fake. No treatment, which is like a wait list group, or an active comparator, which is like physical therapy or chiropractic or exercise or something else where both treatments are beneficial. And so we said, yeah, we'd like all of those types of articles to be in this review. And then here's where the outcomes came in. So function,
Function is a very broad term.
it really is. And Tripp was talking about how their definition of function includes these different categories. So pain was one of the categories of function, as well as activity, sleep, mood, stress, health-related quality of life, and physiological outcomes.
So that would be things like blood pressure or heart variability or, other things.
So we were excited because this was way more than what we expected. We didn't, really think about all of these different aspects. We didn't know that they were going to argue with us and say, no, not just chronic pain, let's pull all of the articles in. So we were very excited, but we were a little nervous. Oh my God, how many articles are they going to find? And we said, clinical trials, that's all we want. And they said, English language is all we want because they don't want to translate stuff. We're like, we're good on that.
And we decided only humans. Well, it's a thing.
It is a thing.
Because there's some really interesting research done in animal models, but that we felt was not relevant to what we wanted, to the information we wanted to capture.
Because mice get massaged a lot.
There are some
I know some mice
I know. Right.
Little rat tendinitis and
Right.
Pregnant rats are collared,
Yeah.
so they can't lift themselves with that.
yeah, there's all kinds
Yeah.
of yeah.
But we said no, not that. We're really just wanting humans. So then we talked about, well, what type of data? Once they find these articles, we had to plan ahead. What data are they going to pull out of it? So before they even did the search, we talked about, here's the things that we want you to pull out of the data. So the first thing is looking at quality of the articles. This Sign 50 is a very commonly used checklist. It's things like, did they randomize? Did they blind? Things that you might have already heard of. So they looked at the articles and they said yes, no to all of these different criteria. This EVAT is something they came up with. This is external validity. What that means is this article, can you take these results and generalize them, out there in the real world setting? We also talked about pulling the PICO information. So who was the population? Exactly what was the intervention? Exactly what was the comparison group? And what outcomes did you use? And then we also were talking about, can we look at the massage itself and come up with different characteristics that you actually pull out of there?
We'll talk more about this strictum thing. It shows up over and over again. We're going to define it later if we can keep Jerrilyn on the floor, because she gets very excited talking about the strictum.
So here's all of the things that we were having them pull out. The strictum, that stands for Standards of Reporting Intervention of Clinical Trials of Massage. This is something that we developed. There's the same thing called StrictA that was already out there for acupuncture, and we revised it for massage. And so we were interested in things like who actually did the intervention, which body parts did they touch, what was the depth of pressure, how long was each visit, all of the different components that as therapists we would want to know.
Just checking in. How are we doing for questions? Are we good? I want to first I'll put in a comment. As a non-academic, that's me, a non-academic reader of a lot of research, I get very frustrated when I read an article that says it's about massage, but it's not clear who gave the massage. I don't know if it was massage therapists. I don't know if it was someone who got trained by a massage therapist or not. Or sometimes it's even machinery, right? And so we, the foundation, decided to take advantage of this opportunity to say, in the papers that represent massage therapy, here are the elements we want to see reported on. In order to help create a standard for reporting for people who are writing research papers about massage therapy. So that's it's sort of a side benefit, but it's going to help future systematic reviews and meta-analyses be much, much more effective because people will be reporting in the language that can translate from one paper to another. Make sense? Good? All right, so now I'm ready for your question.
Well, that wasn't a question. You asked, are we good on questions, and I said thumbs up.
Oh, thumbs up. Awesome. Okay.
And one thing I'd like to say is that as they did all this data extraction on the articles that they eventually ended up with, we have that in a database. And it's available to you for free on our website. And so if you want to go in and you want to look at, okay, I'm interested in all of the articles that look at this specific type of massage or this specific type of, client, you can do that. And so I encourage you to use this database. Now, we're not expanding it. It's only the articles that they already looked at full data, but it's available to you. So if you're interested, once you hear all the results and you think, oh, you should have limited it by this, great, do it, because we want this information out there. So this is what the strictum components that they pulled, every single piece of this out so that we could take a look at what's missing currently in clinical trials of massage therapy. So what can we encourage researchers to put in there? What is it that we want to have in there? What, how can we try and help that process? And then what they also did was we talked about when they do the meta-analysis and they pull data from the different articles, how do we want them to divide it? Because they can't just throw it all in one. And so we have to look at population. Are there different populations that we can divide this into? Are there different outcome measures that we divide it into? Are there the different comparators that we divide it into? So we can look at the data in many different ways. And not all of these pieces have enough data for us to even look at.
Oh, thank you. Good. So, the next thing that happened was we had to learn some vocabulary about this process called the grade analysis. This is a way of coming to a conclusion about the strength of data. And in a grade analysis, basically there are three choices in how we describe the strength of data. And the choices are strongly in favor of or against the thing, in this case massage therapy. Okay? Weakly in favor of or against massage therapy, and no recommendation. But here's the thing, because this language can be a little misleading. Strongly in favor of means the data is so consistent and so strong and so predictable, we're really sure that more studies are not going to change the trend for this question. Make sense? Weakly in favor of does not mean, well, I guess it's okay, which is sort of how I read that. Weakly in favor of means there's a trend, but we think more research will make that trend even stronger. Make sense? It's hedging the bets just a bit. Are we good? Are we good? Weakly in favor does not mean, I guess that's okay. It means we see a direction, but we have to be open-minded to being surprised about that. Okay? And then no recommendation does not mean, oh my God, whatever you do, don't give them massage. Okay? That would be strongly against. Okay? No recommendation simply means there's no trend. We don't have enough information to say that massage is a good thing, or massage is a bad thing, or massage is effective or ineffective in the context of this question. Everybody good? Because these are going to come up again. Yes, Ken?
I'm wondering if strongly against even means, oh my God, don't give them massage, or if it just means it's really clear massage is going to help.
Yes, yes, that
It's
too.
really different than massage is going to harm.
That's
Right.
true. And one of the most interesting things that we found, one of the things that made our work group most excited was the safety levels that we see reported in the literature for massage therapy. So yes, you're quite right. That strongly against would be more, it's more likely that we have clear evidence that massage just isn't working the way you think it is. Okay? All right, so once again, strongly in favor, the trend is so clear and so predictable that we're not worried about it ever reversing direction. Weakly in favor, there's a good trend, but we think it could be stronger, and no recommendation simply means not enough data. Right? That's worth dwelling on because it influences how we read and how we report on what we've learned. So it is 2:43. We're thinking to just go straight through. If you need a break, please help yourself. If we finish early, that won't hurt anyone's feelings, but it would also leave more time for questions. We could even explore the database or something, whatever, you know.
Do you guys want to take?
I just want to stand up.
Okay, by all means, take good care of yourself. Good. So with all that said, shall we talk about results? Yes. In the past, we send people away now, and this is the way we're sure that they will come back. Okay, so here are the results, and I'm so glad Jerrilyn lets me do this slide because it's one of my favorites, and it's very hard to read, so here we go. All right, so the top thing on the slide, you don't need to read it, I promise. What it says here is articles identified through the database searching, and we had this big, long string of search terms. The number of articles that were pulled from that first search string was 4,099 articles about massage therapy.
And they're all clinical trials. I mean, you know.
Yeah, all
they have
clinical
it in
trials on
English.
humans in English.
Wow.
With,
Wow.
yeah,
Right?
right? 4,099 articles. And this was in 2013. Okay? It's more now. After the duplicates were removed, we still had 3678 articles screened for inclusion at the screening phase. We'll talk about inclusion and exclusion criteria in a bit. Anyway, by the time we got down to here, we had 99 articles about massage on the wall. We had 99 articles that fit all of our criteria for inclusion and exclusion parameters. And the conclusion from the Samuele people was this is way too big to be one article. And the way we really need to move forward is to go back to some of those divisions that we talked about a little while ago and to break these articles into 3 different patient populations. And there's no crossover. None of these 99 articles that we ended up with crossed over from one group to the other. We wanted to keep them really clear cut. So we ended up actually with not 1, but 3 systematic reviews and meta-analyses about the impact of massage therapy on function for people experiencing pain. And the 3 population groups that we ended up with were people in pain related to surgery, and we had 16 studies in that group. People who are in pain related to cancer, and we had 16 studies in that group. And the largest group, they call it all populations, and it's 67 studies. Now, in that all populations group, the Samuele people often sort of, as a shorthand, said, we're just going to call that like the musculoskeletal pain group, because that was the majority of the populations that they studied. But my feeling is that really shortchanges it, because there were people with pain related to things other than orthopedic injury. All the fibromyalgia pain patients and studies ended up in the all-pos group.
Okay. They were really looking for categories that they could then, I don't want to say market, but provide to different types of healthcare providers.
Yes.
And so they were excited because they're pain experts. They're not just massage therapy, they're pain experts. So they wanted to send something to the surgeon, send something to the oncologist. That all pops in their heads. They were looking for disorders that people would have where they would go to their primary care provider. And so that's kind of the way you could think about it. Who would go to their primary care provider? Neck pain, back pain, fibro, things that are typically musculoskeletal, most of them are, but nothing, more huge like surgery. That's what we're doing. Yeah.
Okay. So in the surgical populations, there were 16 studies in that, and we had enough data that was apples to apples to have 8 in the meta-analysis. In the systematic review for cancer, we started with 16. We had enough data that we could include 9 studies in the statistical meta-analysis. And in the all populations group, we had 67 studies, and 32 of them have translatable data to be included in a meta-analysis. So I want to just offer a little bit of context here. I read systematic reviews because to me that's like, let's cut to the chase and see what all this, it's fine to read a pilot study with 16 people, but if I can read a systematic review with 5 of those all together, now my N has gone up to 5 times 16. Right? Among the biggest systematic reviews I've ever read and understood, we're talking 5 or 6 studies, right? 67 studies in the all-pops systematic review. Jerrilyn, is that unusual?
Yeah, that's really huge. It really is. And like Ruth said, I read a lot of back pain meta-analyses for lots of different types of treatments, and I read meta-analyses where there's only 3 or 4 clinical trials included in those, and that's not uncommon.
Yeah. So one of the reasons we can make the big statements that we can make is it's highly generalizable because we're dealing with large groups of people with data that is collapsible. Okay? Are we good? Sometimes I start those sentences and I'm not sure where they're going to end, so I just have to check in. So now I think it's on you.
One of the things that we were concerned about is, okay, so we have all these articles. What if they're crappy?
Yeah, what if they're crappy?
We're like, I hope they're good. And so what they do is when they were going through those checklists of did they randomize and did they blind and all of that with those Sign 50, they were able to categorize. Was it a high quality study? Was it an acceptable quality? Or was it a low quality study? And they were pretty happy with acceptable or high quality. So we kept our fingers crossed that we wouldn't have very many low quality. What do you guys think happened? Do you think we had mostly low quality?
We probably had some.
We had some low quality. Do you think our majority was in the low quality?
No.
Do you think our majority was in the acceptable?
Acceptable.
Do you think the majority was in the high quality?
I'm thinking high only because you seem like you're excited.
And wait, before you
Don't get too excited.
before you say, I'm going to say this is not an arbitrary, subjective judgment. This is based on the grade analysis. I'm sorry, on the Sign 50. On the Sign 50, which is a widely accepted, validated way of assessing the quality of research studies.
And
We
we
didn't
didn't
make
do
this
it.
up.
The Samuele folks.
Yes,
were the
Samuele.
ones that did it.
Go ahead, please.
I had a question sort of tangentially related to quality. And I'll take a second to explain why I'm asking. It's not about this meta-analysis, which I believe the results are that massage is probably going to be fabulous for pain, but we had an enormous argument at my school amongst the staff about a meta-analysis that was inconclusive about whether massage increases cortisol levels.
Oh yeah, I know that. I know that study.
And I had faculty who were saying it must. It's just the physiology is how it works, and they were really angry. And it must be that all these studies were financed by insurance companies who don't want to pay for massage or something. So I thought that was crazy. But is there a way to know who funds the studies?
Sure. In the acknowledgments, they always have to disclose who funded the study.
Is it possible in the meta-analysis that some of them were funded by folks with an extra grant or something?
For this one?
For any?
I
for every
can't remember if
meta-analysis.
that was excluded or not, but you can look at the original articles and see who funded it.
Just one comment to that point, though, is that even if, let's say Monsanto helps fund some kind of study, some kind of research on nutrition, it doesn't mean that Monsanto goes in and has any direct contact with the scientists at all. Most of the time, not at all. And the scientists, they just do the work. It's just that they gave money to whoever it is that employs the scientist. But so I mean, there is.
But they only publish the ones that come out the way they like.
Right, but the rigor is still in the study.
Sure.
Even if they're leaving out the ones they don't want to
Yeah.
publish.
And
Let's take it back to this.
I'm sorry, yep.
But there are articles looking at privately funded versus federally funded, and the privately funded, when you look at new cardiac heart drugs, the privately funded are statistically significantly better, showing the new drug is better than if it's federally funded, looking at new drugs for cardiac. So there is some research in that. Anyway.
Thank
There's
you,
research
sorry.
on that research.
Exactly, because it's an important factor is to look at that. And there can be some biases, and there, and especially in the analysis portion of it, there can be biases.
And actually, to be fair, that could even be relevant to this, because if these were all funded by folks who want to prove that massage is fabulous, that's biased.
Right. And that's why it's important to look at lots of articles in a meta-analysis, and not just, when there's only 3, it makes me concerned, right? Could all of these be biased in some manner? So here's the quality ratings. No, they weren't all high quality, but pretty darn good between acceptable and high. When we got to this point, Samuele was all of us. They were so excited. This isn't common. They didn't expect this. They had just done a study on, was it self-care?
Yes.
And
They had like a whole special edition on
they had a special edition in a journal, like a whole issue, just on self-care, where they did meta-analyses looking at different things. They didn't have this good of data, and they said, I wish we'd known this sooner because this is what we'd like to promote. So they were really excited about this, as were we, because we could, we hear a lot about these low-quality studies. Well, sure, there's some low-quality studies, but the majority of them were acceptable, which is great.
Jerrilyn, can you say something, because I've asked you this in public before, and I love your answer, why we didn't just throw out the low-quality studies? Would you like me to remember your answer?
Sure.
I mean,
Which point are you trying to make me make?
No, I mean, it's a simple question to ask. It's sort of an obvious question to ask. If you have 7 studies that are, in your all-hops that are low quality, and you have 60 that are high quality, why not just throw out those 7? And the reason is that what makes a paper low quality may be something about when it was written. So, for instance, there might be a project that is old and didn't have the same reporting criteria that more current projects have, and that would throw it into the low quality corner, even if the rigor of the study was really good. It was just didn't meet a more current standard for reporting.
So the researchers now have to abide by this thing called consort guidelines. And the consort guidelines, when you're writing up the study, you are mandated to include certain things. And most journals have the consort guidelines. And so these Sign 50 things are all in there. You have to describe the randomization. These acceptable and these studies were dinged sometimes because they didn't describe how the randomization happened. They just said we randomized, but they didn't actually say we used a random numbers generator based off of this program, and then we put them into manila envelopes and sequentially put them, and somebody who was blind to the study, they didn't describe all of that. Now, as a massage therapist, you may not care, but as a researcher, I want to know what you mean by randomized, because people say randomized a lot, and it doesn't mean what I think it means. They also didn't talk, they had problems with allocation concealment. That means, do people know which group they're in? Do you know if you're getting a massage or not getting a massage? I mean, that's a really hard thing. So that, using the Sign 50 that they use for all of their studies, we're always going to be dinged on that because we can't do that for massage. If it's, did you get massage or acupuncture, you know which you got. So sometimes there can be allocation concealment. If you say, oh, the study's kind of full right now, we're going to call you back in 3 months, and they're actually in the wait group. And then they come back and go, oh, guess what? You were in the wait group, and so now we're going to, So there are some ways, and you can do like a fake massage. They had no placebo massage techniques for this. I'm also a chiropractor, and I've done a lot of clinical trials in chiropractic, and I've been on some collaborative studies where the placebo to the chiropractic group, which was considered active, the placebo or the sham was light massage.
Which was really bad for chiropractic. I'd imagine the results were
You know?
terrible.
Yes, and there was a study where both groups got better, and it was just like, wait a minute.
We can't publish that.
Well, you know, I'm like, oh my gosh, you look at massage, it's doing great. And this was before I was a massage therapist. And my boss, who was a PhD, said, no, it shows you that neither of them are good. And I'm like, no, it doesn't show that. We fought so much that I removed my name from authorship because I couldn't say what she wanted to say. And this was a clinical trial. Anyways, that's besides the point. So these are things that we look at. This is a statistical way that researchers are supposed to analyze the data. We pretty much all do it, but we don't say we did intention to treat analysis. So really, with some of these things, it may have occurred, but the researcher just didn't write it up. It just didn't get in there.
Those three in purple are the reasons why those 7 studies or
The most common.
These are the most common dings out of all of these. This is the Sign 50 checklist. The purple ones are the ones that were dinged the most. That, okay, massage therapy researchers who are writing up these articles, you didn't do this, you didn't do that, you didn't do this.
And so this informed the strictum, right? What's consistently missing?
Well, I was going to ask, and maybe this is naive, and certainly now that there are more and more standards about how you write up research and even case reports say, but is it naive to think that in fact a lot of low quality studies don't ever make it to the meta-analysis because it's harder to say you're comparing apples to apples if I didn't tell you, you know, what if I didn't clearly define my population, if I didn't clearly define the intervention, like is it fair to say that in a lot of ways when you get to this level of research you've already kind of eliminated a lot of low quality research in that it's just hard to match it to other research?
Not necessarily.
Okay.
I mean, there's
Okay.
still clinical trials. I
Okay.
mean, unless they didn't do the outcome measure that you mainly want to have, or
Okay.
they didn't have the population. But sometimes researchers who are doing meta-analyses will throw out the low-quality ones. So
Okay.
it depends on the methods that the researcher wants to do.
Okay.
Sometimes, and this has happened to me, I'll get a call, hey, you did that clinical trial? Yeah. Did you do intention to treat analysis? Yeah. Well, you didn't say it in the article. Oh, well, let me just send you my confirmation that I did. And then in the meta-analysis, I don't get dinged for that. And that has happened. And so sometimes they'll do due diligence and actually call all of the researchers to see, did you do this, did you not do, you know, to make sure that is this quality or not.
So this is sort of a similar question. When you talk about low quality studies, they were good enough to get published in a peer-reviewed journal.
Exactly.
Right.
I'm sort of curious why almost. Like maybe the bar
Again,
should
changing
be raised
standards.
in the peer-reviewed journal.
Standards that evolve over time. We get better at things, and we raise the bar.
My question, and you might have covered it, clinical trials doesn't mean doing the treatment.
That's correct. Yeah, good question.
How many?
A clinical trial is an experimental study where people are randomized to groups. So it could be as few as 10 people, 5 in each group, you know, or to infinity. And so the way you can tell it's a clinical trial is how did people get in their treatment group? Did they decide for themselves, or were they randomized into that group? Did the researcher place them in the group? Good question. Thank you.
And in the database, it is listed how many people were involved in each of the studies. And I don't remember if it's in the slideshow. Yeah, it is. We'll give you the total number of people who are referred to in this data gathering.
So between the two that you just mentioned there then, which is preferred, which is a higher level?
The clinical trial, the randomization.
The randomization
Oh,
is
yes.
what I thought.
Because when you look at who chooses one treatment over another, I mean, if you just very broadly think of who would choose to take a pill versus who would choose to go to a massage therapist. Sometimes we can categorize, okay, people who are interested in massage therapy might have a healthier lifestyle, might eat more healthy foods, might take better care of themselves. If you let people choose, already it's biased because that group is healthier and the group who takes the pill generally might be more pill-oriented. So that's why randomization, you mix everybody up and now you're getting equal pill-oriented and equal healthy, if that makes sense.
Yes, it does.
And so randomization helps decrease that bias.
So if you have, excuse me, just one more minute. If you treat 10 people who have problems with their shoulder, that's a broad term, pain in their shoulder, then that could be made into a clinical trial.
Do people get randomized to their treatment? Which treatment they're in? Are there multiple treatments?
No, anybody who comes in with the shoulder, now it could be in your deltoid, it could be in your supraspinatus, it could be arthritis, it could be anything. The cause of the thing could be random.
No.
Oh yeah, no, that's not randomization. Nope.
So the word random, don't mix that up with randomization. So if you know, like I could randomly pick up a pencil, or I could randomly choose some of you to do a survey. That doesn't mean it's a clinical trial. The clinical trial means random allocation. Which treatment group did they go to? And so it's purely looking at the treatment they get if we're looking at randomization, and so trying to define if it's a clinical trial. So it's the term random. It can be very confusing.
Sorry, I just want to add something to help clarify. Randomization is more than just you end up in a random group and you get the massage, you get a placebo. The groups themselves have to look as much alike as they can. So if there are 10 people and half are women, one of the groups is going to have 2 women, the other's going to have 3, rather than all 5 end up in the same group. And they're randomized for age, for as many characteristics as you can come up with. You try to make the groups randomly similar, right? So you don't just put people randomly in groups. It's actually a really systematic process to randomize. Does that make some sense?
Yeah.
Systematic randomization.
Yeah.
Yeah, it's very complicated, and the more I learn about research, the more important I find that randomization is.
But we can't randomize people to, not all studies can be randomization. If we're looking at does smoking lead to lung cancer, do we want to randomize you smoke 3 packs a day and you smoke nothing? We can't ethically do that. So we can't randomize in every study because sometimes it's just not ethical. So.
No, never mind. I'll ask you later because, yeah.
All right, so anyways, we were pretty excited about this. They were pretty excited about this. We were like, so what's the results now? We really want to know what happened. They said, well, okay, well, let's look at strictum first. These purple parts are the ones that, again, the researchers in these clinical trials did not do a good job describing. And so we need to really stress to researchers when they're writing their articles, please include who is it that's doing the treatment. And really, what is the setting? Is this in somebody's bedroom? Is this in a hospital? Where exactly did it happen? And what exactly are you using as the control or comparison? And why? What is it? Sometimes they'll just say a control group. What does that mean? Or a placebo. What does that mean? So really, these were the areas that they felt we really need to step up our game in these clinical trials on massage therapy.
And I would like to add on the practitioner background that among the limits we put for which studies we would include were that the person doing the massage needed to be a massage therapist or needed to have been trained by a massage therapist. So for instance, a parent trained by a massage therapist to do something with their child, that would be acceptable. But they had to be a massage therapist. Not only that, they had to define themselves as a massage therapist. And that ended up, can I go ahead and do this? That ended up excluding lots of really good papers on shiatsu. That will have repercussions. Okay? So those are the limits, those are the parameters we put on it.
And it doesn't mean shiatsu is bad.
No, not at all.
When you're reading an article,
right,
it's not always being excluded because something is bad. It's just in this article, for this purpose, we're only looking at this. So if you're interested in shiatsu, please look at it. Or if there's things we excluded, all the animal stuff, please feel free to look at it, because we need to look at this in lots of different ways.
So, you know, if somebody wanted to fund a meta-analysis on shiatsu, you know, or on massage performed by shiatsu trained practitioners, those studies might then be included.
They'd have to be included.
Yeah. So it's not that they were not good studies, it's just that the inclusion criteria did not meet what you defined for this meta-analysis.
Yeah, we had to create some definitions to put some limits on it, and that's all described.
Just like if they used a massage chair. Okay, that's still kind of massage, but that wasn't in our definition of massage.
Or if a nurse did massage.
Or if a nurse, yes, if they were trained in it.
Oh, okay.
Yes.
If the nurse was
Exactly.
trained by a massage therapist.
Or to do massage.
Or was a nurse trained to do massage from her nursing training.
I think we accepted those, didn't we?
Right,
Accepted
yes,
those.
so it had to be a profession that we would logically think got trained, like physical therapist or a nurse. If it said a parent or a spouse, then it had to demonstrate that it was a massage therapist that trained them.
That's kind of interesting.
Yeah,
Inclusion and exclusion criteria.
Well, we had to
Yeah,
start a
with
place.
somewhere.
Yeah, but yeah.
And Pete's here too, so feel free to speak up at this process, because
Do you know how many of these papers were actually written by physical therapists or people who are
It would be
not
easy to
actually?
find by looking at the database.
Yeah. And the comment I was going to say was about some of those articles that were excluded. They're delightful articles to read, and that's I want to just put that out to you all, that the database is filled with very interesting research. We just couldn't include it.
Well, the database is all the things that we did include.
Yes.
The search
Well,
string
yeah,
brought
the
up
search
things
string, yeah.
that were wonderful, but not a fit for this particular project.
So the database is only the ones that ended up in the final meta-analysis, not the 4,000 who started with.
That's correct. It's the 99.
Well,
It's the 99.
Yeah.
Sorry.
Still.
But you can do your own search string. So you have the eco term.
Yeah,
and we have the search strings in the articles. So all you have to do is just copy that and paste it into PubMed, and you can do the same search. Because they gave you the string, that's exactly what they did. That's the beauty of a systematic review, is you know exactly what they did, and you can copy it. And then you can see how many more are there now today. So, with the results, again, we were looking at this general musculoskeletal population in terms of pain, activity, anxiety, and quality of life. Now notice sleep isn't in there. That's because we didn't have enough articles on sleep.
Or that mentioned sleep as an outcome.
That mentioned sleep isn't right. And so when we looked at pain, it was compared to an active comparator, sham, or no treatment. So we had enough data to look at all of that. But with activity, it was only versus an active or a sham, when there were articles that looked at massage therapy treatment and with activity outcomes, there weren't any or enough to look at that were versus no treatment. And so these are all different ways that we can look at them with all the different types of outcome measures. But not all articles had all of the outcome measures that we were interested in, so of course more research needs to be done. So when we look at like the surgery, if it's only pain and anxiety, they didn't look at things like quality of life or activity, because these are the main areas of focus for surgical patients.
Yeah, we were in this case, we were limited by what the data revealed to us. So we can only report on these things.
Right.
And that goes back to the commitment to that word function, which is reported in so many different ways.
Now notice in the surgery and the cancer populations, most of these are only versus an active comparator. Why do you think they didn't have like a wait list, like a no treatment, or a sham, a fake treatment? Why wouldn't they have that for cancer patients or surgical patients?
We could ask anybody that right now.
Is that ethical?
It's not ethical.
No. I mean, they're in pain.
Exclusion.
They need something. Now, why would it be ethical for up here to have it versus a sham or no treatment?
Drugs.
Well, drugs would be an active comparison.
Right.
Because it's not life-threatening.
Because it's not life-threatening.
It doesn't vary from usual care.
Yep. So usual care. If you think about the typical person with chronic low back pain, how long have they had it? a long time. It comes, it goes, they deal with it. Okay, that type of person who comes into a clinical trial and they're told you might get a fake treatment, they might say, okay, whatever.
How
Because
is it worse than what they
they're just so used to living with it. Versus if somebody's in pain because they just had surgery or they're going through cancer treatments. So.
Oh, my turn.
We're getting towards the end of the actual data tables here.
So this is a way of reporting data. This is not from the study. This is just a sample. Okay. This is a way of reporting data called a forest plot. I will not defend why it's called a forest plot. To me, this does not look like a forest, but you know, whatever. So, but and when I was first trying to understand this, I actually had to get Jerrilyn to talk me off the ledge because that means nothing to me. And she taught me how to read forest plots. And now I get to teach you because they're really, really cool. They convey an enormous amount of information in a very small and easy to read space. So here's the thing, in a forest plot, 0 is the center line, and on one side of the center line, things are better, and on the other side of the center line, things are worse. Or there's a positive outcome or a negative outcome, or a positive outcome and a no outcome, or whatever. Yeah, okay? Percentage versus sham, right? Okay. Each one of these purple dots represents one study. So how many studies are included in this forest plot? There are 4 studies in this forest plot. Good? You already get this. The lines, you have to correct me if I get this wrong. Okay. The lines on either side of the purple dots refers to the variations in results that were found in this study. So in some forest plots, you'll see the little circles, or sometimes they're squares, and they have just a short little line. And what that means is the results they got were really consistent and within a narrow margin of range. And sometimes you'll see them have a really long line, which means their results were just all over the map. Okay? So typically, studies with short little lines are the ones who are giving us the clearest information. Hang on, I got to finish this or I will lose my track. Okay? All right. So, which one of these studies had the least specific information? The top one. Right, quite right. Excellent. And the others are actually, well, the bottom 2 are sort of more or less the same. All right, so there's one last thing to understand about forest plots. I'm going to do my best. Okay? If a study crosses over the center line, that means they got results on both sides of the good or bad or yes or no question, which means the results of these 3 studies are not statistically significant. It's only the studies that are on one side or the other of the middle line that give us a statistically significant finding. Okay, Joe, I'm ready.
So my first question, I'm pretty sure I know the answer to. Those lines are not like confidence intervals or margins of error. They're actual, if that top study had 15 people in it, the 15 people fell along that line. The person who did the worst is on the right end of the line. The person who did the best is on the left.
It is a confidence interval.
It is a confidence interval.
So here's where we think the result is. It's kind of like the mean and standard deviation.
Sure.
But in this type of statistics, it's usually like the relative risk or the odds ratio and the confidence interval. So it's just like a standard deviation of plus or minus.
So we're 95% sure that the answer is somewhere on that line.
Yes, exactly.
Right.
So
Yeah, but if that line's really long,
Well,
then
so now I've got an issue with if it crosses the line at all, it's not significant. If the dot's way on the left and the line's really long, and a tiny piece of the line goes over because 1 out of 100, well.
that's like arguing over p-value that's 0.06.
Right.
Mm-hmm.
Right.
So the line is where we draw the line.
Sure.
And so what we're saying is that when we look at this confidence interval, what we're saying is, okay, let's say this is the sham group and this is the massage group. Here's where the majority of people, fell. Most people in this group got better. but it's somewhere in here. Well, some of those people are on the massage group side. So we don't know for sure what's going on here, what's really the best. Whereas here, no matter where along this line it is, we know it's on this side of the line.
So the side of the zero.
On this side.
Why is
So-
there no confidence interval for the combined result?
That's a good question. So the combined result, the diamond at the bottom, they took all the data, collapsed it together, and now we have one result from everything. And if it's, instead of the tails that they have, they make the diamond like wider. It's like this. It's to make sure that you know that that is the meta-analysis.
So,
Result.
Thank you so much for answering the statistics, but that is as deep into statistics as we're going. Let me say one thing, and then I'll get Carol and Lucy. I forgot what I was going to say. Oh, Carol?
So you said that each of the dots represents one study.
Each of the lines.
And the dot represents the meaning, right?
Well, the center.
The center of the line. The dot's at the center of the
The
line.
effect measure is.
Not always.
Not always. Yeah, sorry.
It's the effect measure. Let's actually look at one of them.
Shall we just look at one?
I
Wait
just
a
have a
second.
question. Can this be, when you first started the conversation about strongly agree, strongly disagree, can that be looked at with this? I mean, like,
That's how we do it.
the,
Yeah.
That's
so,
how it's done.
that's how
yeah,
it's
you're
done.
right. Let's get to the end point here, guys. Yeah. So let's look at one of our actual results. So see how there's a citation here? These are the citations for each of these different dots. But they're squares. So for this one, see over here it says favors massage, favors no treatment. With this forest plot, we're looking at the general population, and we're looking at massage for treating pain compared to no treatment. So when we look at these four studies, which are they mostly favoring, massage or no treatment? Massage. And if here's our line down the middle, how many of them are statistically significant?
All but one.
3, all but one. This
Oh,
one,
oh.
see how it's an arrow? It's so far over here that it
It's
could
off
be
the
other
chart.
chart. Yeah. And so this is saying that for pain, when we're looking at the general population for pain, if you give them no treatment versus massage, massage wins. So,
Yeah, that's not a small finding.
and this is the meta-analysis.
Right. I wanted to talk about, I mean, sometimes people will be disappointed, well, duh,
Yeah.
compared to no treatment. Except that, think about people in your life who are in chronic pain, and they're done with PT, and they definitely don't want to go down the road of opioids, and they'll do anything to avoid surgery, and they just don't have a lot of options left. That's no treatment, right? And now we have data, really strong data, that says the chances that this person will have some improvement in their symptoms with this safe, non-inter. Again?
Intervention.
No, that's not what I want. Invasive, non-invasive intervention. I knew there was a V. Non-invasive intervention, the chances that they'll have at least some success are really, really good. And that's what that person I just described, that's a lot of people.
Well over 95% sure that they will.
Yeah.
And just to be clear, if if the studies were closer to the midline, if the meta-analysis diamond crosses over the midline, we basically say the whole result of the meta-analysis is it's not statistically significant, right? Okay. So that's everything is to the left, but there's a piece crossing over.
And sometimes what happens is more studies happen and they redo the meta-analysis, including those, and it just pushes it
Okay.
over. Yeah. Because sometimes there's not enough data to really clearly say statistically, yes, there is. Okay, so these are all kind of older studies, 03, 04, 06, and 10, because no treatment, that's not really a common thing as much in clinical trials anymore. So if we look at versus sham, some of these are also older, but here's favors massage.
Here's the center line. It's hard to see, so I just said,
Oh, yeah. And the other is favors sham, and see how there's also kind of grouped to the side. Now with sham, they're a little bit closer to the line or they're over the line, because when you're not sure what you're getting, people who get a sham, they may be more likely to say, yeah, I feel better, not realizing what they're getting is supposed to not help them, but again, it might.
So you
Well,
said the
sham
difference
massage will
between
help,
this
right?
and the other is the placebo.
Yes. So no treatment, or was there a placebo treatment?
And the difference, the shift, is that effect is the placebo effect.
Yes.
And the shift from the zero line to the center of that diamond is the effect of massage.
So, I mean, someone's asking about an example of this sham massage. One of my very favorite studies compares massage to a person receiving detuned ultrasound. Right? Okay, so they're getting touched by an ultrasound machine. The operator of the ultrasound machine does not know that the machine has been detuned. Okay? And so it's a blinded sham, right? And the person doesn't know whether they're in a group, whether they're in a study that's studying ultrasound or studying massage.
Do you ever see those infrared pads? We had a study where we flipped it upside down so the infrared was actually going up, and laid that on the back so that the patient was lying prone, and it was upside down, so that was the sham. They thought they were getting infrared, but they weren't. So there's lots of different. This wasn't massage sham. This was a different sham, something else.
Some comparator that was plausible.
Now the cool thing is the next one, where we're looking at the general population, comparing massage to all other active treatments. And there were all sorts of different active treatments, but there were a lot of studies that looked at this. And this crazy mess is what it looks like. And so here is the line, but see how there were some where it actually, the other treatment was beneficial, versus on this side, this is all the ones where massage was beneficial.
And the diamond is just touching the line.
So this p-value is 0.053.
Oh.
Oh. One more study and we might, The interesting thing that somebody needs to do is pull all of these out and look at what conditions are these. Because remember, this is general. This is like all of the primary care things. Maybe there's one type of condition where massage just isn't effective for that. This also, what is the active control? You know, maybe acupuncture is awesome for everything, and when they compared massage to, you know, some other active comparator medication or something else, maybe that's where massage always, you know, rose to the top. The cool thing is that, you know, really, this is very, very close. And this got the Samuele group extremely excited. They felt like this was a total win for massage. Because, you know, when we're comparing so many different types of conditions with so many different comparators, and this is what we end up with, that massage really rocks. You know, so they were pretty excited about this. Any questions? One thing you can do, if you're interested, you can go to that database on our website, and you can just look these each individually up. There's different columns. You just pull up that one name, and you can say, see what was the condition they were studying that had pain, and what was the active comparator for these studies. And you can take a look at that. So,
We're back to me. So now we have the studies that have been pulled out and the data has been crunched, and we have these forest plots that Jerrilyn taught me how to read. And the group of subject matter experts, the work group, gathers together again to look at everything that's been gathered. Now we're focusing in this talk today just on that one all pops. Today we're not. Okay, yeah, throw it in the end, but we're not focusing on the cancer populations or the surgical populations, right? But the job of the work group was to look at that data and coalesce and decide if we thought massage should be, in this situation, strongly recommended, weakly recommended, or have no recommendation. And we did that based on where the diamonds ended up in the forest plots, because that's the only way to be really objective about making that. So what we came to is that within our, for messages to these stakeholders, the general population, other healthcare providers, and policymakers, this is where we came to, is that for the situations where we made a weak or conditional recommendation, again, it's not, well, it's kind of okay. It's more that many people might benefit from this, but maybe not everybody. We need more data. Okay? The message for the weak recommendation for healthcare workers is this is an option if this intervention is in alignment with the values and the desires of your patients, right? And the message for policymakers is we're not ready to really stand up for this yet, but watch this space because this information is changing quickly.
And we're not
It
ready
needs
to
more
stand,
debate.
we're not ready to stand against it, right? That this, we can't hardly endorse it, but we shouldn't be.
We shouldn't be ruling it out.
We shouldn't be ruling it out, or yeah.
Right. Yeah, exactly. We can't endorse it yet based on the data. If only data informed more policy decisions. But this is a place you have to start a place. Right. And this is what we came up with. So when we had a strong recommendation, the message for the population was, we think a lot of people are going to really appreciate the benefits that this intervention has. For healthcare workers, it might rise higher up on the list for alternatives that people might suggest for your client who has back pain, who doesn't want surgery, and who doesn't want opioids, and whose physical therapy has failed them, right? Here's an option.
So high up that it might not be an alternative.
It might be a first choice rather than a last choice, but we have to meet the system where it is, right? And the message for policymakers is this is effective and it works. And for me, the next step here is to start gathering data on cost effectiveness. But let's compare cost effectiveness of massage and back surgery, shall we? Yeah. So it's hard data to gather. It takes a long time. It's very expensive. But that's what's really going to sway, obviously, the policymakers. But we have a starting place that makes it worth investing in that kind of research.
So this was the table. When we look at the diamond, we actually can have numbers associated with that, and that's what this effect size column is. So here is like minus 0.44 means it's just a little bit off to the left, and then this 95% confidence interval is that tail, so it goes from 0.4 to 0.05, and there were 5 studies, which equated to 655 people, and so that's how you begin. The numbers aren't as important. I'm going to show you some of the cool stuff. This is how confident are we in this effect, and we had to grade and give it ABCDs, right? And we also did looked at the safety. So safety was something that we didn't really talk about, but they pulled out of every study that they could find it, is this safe? Did anybody get hurt by massage? And so they would give it a 0 if there was, overall there wasn't any data. They'd give it a +1 if, yeah, it looks pretty safe. They'd give it a +2 if absolutely it's safe. And then there's -1 if it harms people somewhat, -1, -2 if it really hurts people. And so when we were looking at the safety grades, as well as how confident are we based on how many studies, as well as the effect size, all of that data then led us to the strength of recommendation with the, we support the strongly weekly or no recommendation. So here's what was done. And again, I just want to point out this is for general pain pop. Here's our different outcomes. Here's pain, activity, mood. We did not look at all of the forest plots. We don't want to bore you with every single one. You can see them in the papers if you want. But these are the 3 main outcomes that we found for the general pop. And it's versus sham, versus no treatment, versus active comparator. All right, so here's what was found. So we were moderately confident in these effects based on the size of the population, how many patients, how many studies. The safety records were all good, +1 or +2, which was huge. They were so excited about that. And then we had the strength of recommendation, mainly weak and strong in favor. Here when we're looking at pain, activity,
Activity did not have as much data, and it did cross that line, so we're really not sure. But again, activity has lots of different types of outcomes, so it's hard to really define. And then when we looked at mood, again, it's weak in favor when we look at active comparator. And so we were pretty excited about these weak and strong. Now remember, this versus active comparator, it wasn't statistically significant because it was 0.055 or something like that. It was just touching the line. But they felt like because it was so safe that they still felt like it should be a weak in favor, which is a huge win for massage. So again, even when we first showed this to the board, they were a little disappointed. They were like, well, weak? What do you mean weak? We saw 4,000 articles initially. What's going on? No, that's good. That means we're headed in the right direction. We need more research.
Which is what you often find, because it takes, it takes a. You'll notice that researchers don't use the word proved and proven, and there's a reason for that, because things can change. So I wish the language with this were a little bit different, because it just sounds sort of milquetoast. And it's not. It's a really good finding. We just need to learn how to communicate that, not only to our so researchers get this, but when we take it and talk to our patients or talk to other healthcare providers, we need to understand what this really means.
So in 6 minutes, we can have commercials for massage therapy, reducing pain, and instead of 5 minutes of 20 side effects, it'll say, no side effects.
Right.
With that same voice. Side effects do not exist.
So if we want to look at the cancer pain population, skipping over all of the forest plots, which again, you can look at those yourself. But remember, with the cancer, it really was pain, sleep, stress, mood, and there was only versus no treatment and then versus active comparator. And what we found with the cancer one is no recommendation or weak in favor. There wasn't as much data looking at massage for cancer type pain. But the safety was unbelievable. They were so excited. Now again, the pain experts that were sitting on this task force, they were military people, and they're looking for something like this. And the opioid crisis is definitely affecting our veterans and our active duty. And so they're looking for something that is worthwhile. So we really believe that these articles are going to help move policy forward, not just in the general population, but also in military populations.
That's a good question. So the first line, 167 participants, and 3 is that study.
This is, yes, 3 different studies for that.
So then when you go to the next line, it's 708. So it's
Yeah, the
So
10 studies with a total of 708 people.
If they count all the patients in these 10 studies, it equals 708.
And so on the effect side, you've got 6 studies. Is that because?
Yeah, and so sometimes with these studies, like here, they were able to use all of them in the analysis. Sometimes if it doesn't exactly, if they're
They can't
apples to
crunch the
oranges,
numbers accurately.
or if the data that they pull out is such that they don't, the study didn't include all of what they needed for the analysis, they can't use it. Or, remember we saw that one arrow that was like way off to the side? A lot of times they'll just throw those out of the analysis because those seem
They're such
maybe
weird
biased.
outliers.
Yeah, they're
So
outliers.
how does it, the difference in that, so in that 4 studies basically were crunched into the data,
Right.
effect size, does that change, it must change the confidence in the estimate of the effect?
Yes. True.
Can I talk about the lead study when we're on this? Okay. So one of the speed bumps that happened while we were collecting this data and getting close to writing the articles for this is that a systematic review looking at massage therapy for pain related to cancer came out with a really different finding. And that's great, that's awesome, but when that happens, you have to sort of explain why that might have happened. So this was a study, and I haven't read it recently, I don't remember how big it is, but the parameters or the research question is a little different because it's really just about pain, not about function relating to pain. And the inclusion criteria are very different because the study came out of China. So it included studies that were in Chinese and studies that included shiatsu. And so this is the Lee study, if you've run into that. And so their final effect size were much, much stronger than ours. And that's just a matter of inclusion and exclusion criteria for where you started. It doesn't mean that one study is better than another. It just means they were asking a slightly different question.
And we could redo these analyses and include all studies that have only pain measures. And I think for cancer studies, we find a lot more. But remember, originally, we were interested in looking at people who have pain, what is their function? Does their function change with massage? And so when we found all these articles and then we divided them, we still only had articles that had pain patients that only had, that had to include function as an outcome. And so there's probably just so many more. But at that point, we had already, pulled it and decided we were going to divide it up. And so remember, pain was one of the function measures, so we were able to look at it. But if we're looking at studies that only included pain, this would be a lot more studies. So let's look at surgical. Remember, surgical was only versus active comparator. And again, it was weak in favor and +2, which was their one. So they were very, very excited. They felt like this is definitely something that people who are surgeons need to look at. Because if somebody has pain and they're taking all of those painkillers and then they start getting all stopped up and now they're straining and they're popping open stitches, is there something else? Hey, guess what? Yes, there is. And even though this is weak in favor, there's more studies coming out now. So I was just showing.
You're reviewing one right this
I was just showing Ruth. I have this stack of articles I always carry around with me. I'm an editor for Leon Chaitau's journal, JPMT, and so I'm always reviewing articles. And one of them that I was showing Ruth was actually a different Journal of Alternative and Complementary Medicine, sent me an article to review, and it's on pain and massage for surgical patients. They're coming out all the time now, and so hopefully we can make this a stronger point. But even when we just look at the number of studies that were included, 7 and 7, we have, this is great. We're absolutely headed in the right direction.
And for people who are trying to build relationships, say for a hospital-based massage program, this is the kind of data that can really carry some weight.
Yeah. So here was our bottom line takeaway.
I love this. Jerrilyn made this chart. It's so cute.
I understand this.
So you're
It's a little easier than a forest plot.
Got it.
I teach study design all the time, and I use, the words like randomization and blinding, and students are like, oh my God. So I always end up with, okay, let me just show you with stick figures and smiley faces, because it makes more sense to all of us. So, especially after we cross that lunch and it's getting late and all that. So, anyways, here, these smiley faces are the different boxes where the question was somewhat answered, where we have enough data that the question could be answered and there was potentially weak in favor. These empty boxes are places where there wasn't enough data. We don't know the answer to those questions, and researchers, hey, why don't you do some of this? And so when we talk about, what's the research agenda, where should we start? Oh my gosh, start anywhere, because we really could use more research in all of this. There really was only one strong in favor, but we really could use more research in all of these categories, especially these that don't have any smiley faces in.
So again, we use the term musculoskeletal pain here, but that's unnecessarily narrow. This is pain for which you would see a general practitioner, as opposed to pain related to cancer or surgery.
So just a couple more slides. Takeaway for researchers. I tell researchers, please, please, please look at consort guidelines, strictum guidelines, the Sign 50. Make sure you're covering all of your bases, because otherwise it's going to look like your research is sloppy and poor when maybe it's not. You're just not including all of the information. Please include all of that. Really, work on consistent descriptions. What outcome measure are you using? Because if they're all over the place, we
can't collapse it into a meta-analysis. Oh, I made up my own outcome measure. I'm very unique, and I thought this is a great way to measure. Well, sure, that might be a great way to measure, but we can't ever compare that to anyone else unless everybody else starts using it. So, and make sure that you look at specific gaps in the articles. Like I said, using these types of reporting guidelines help. Please, 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 researchers out there, describe what you did. And I say that to myself too.
Good. So some of the takeaway messages that we derive from this, that apply to practitioners and massage therapists, is that what we found was a wide variety of types of massage were described. So we did not hone in on discovering any one modality was fabulously different from any other. So no recipes. We can predict that massage that is carefully administered by licensed massage therapists or people trained by licensed massage therapists is probably going to be safe. That's a very important piece of information. We find this takes us back to the beginning again, that pain is multidimensional. And one of the things massage can do is add to the quality of life of someone who's experiencing pain, so that while, Jason will be familiar with this analogy, while someone's pain in their life might be this big, if we can help their life to become this big, because we've added some new ways of experiencing their body, even though we haven't necessarily reduced their pain, we have improved quality of life. We've reduced the importance of that pain. Does that make sense? Or the impact of that pain. And because, massage therapy has to do with so many things about social support systems and improved mood, it really helps us to feed into that biopsychosocial model of pain management. We know that we found data about massage in lots of different settings, in hospital settings, clinics. Franchises tend not to conduct a lot of research, although that's changing. But massage is something that we see in the public in lots of different places, and that was reflected in some of the data that we got. We talked about possible messages. If you have the opportunity to chat with an insurance adjuster or an insurance commissioner in your state, this is the kind of data that can maybe influence some of those decision makers. When we talk about messages for our clients, that term "weak in favor" sounds really weak. So, I want to help you or encourage you to think about how you might represent what you've learned as you're talking to a new client or as you're talking to a new venue where you might be doing your massage. That the trend is really strong, and we're confident that more research is going to take us even further down that road. Okay? We talked about the biopsychosocial approach, and what we find with that biopsychosocial approach is that any single intervention is not usually as effective as when we use that with client education, movement, general tools for well-being.
So other than the 3 meta-analyses, there were also 2 commentaries that went in the journals. This quote came from one of those commentaries that an MD, it was Dr. Bockenmeyer, had wrote. Massage therapy is the evidence-based new thinking that will, with other integrative non-pharmacologic approaches, help pain medicine overcome the current opioid-focused old thinking that has devastated so many lives. This was not our voice. This was the pain scientist's voice.
Are you yawning or dropping your jaw?
Right. So they get it. They understood. This was impactful to them. This process was scary, but it was very fruitful.
It was a risk. We took a big risk, yes, in doing this. Because it could have not worked out so well.
Yeah. All of this quote, like I said, is in one of the commentaries. All of them are free at the foundation.
Oh, can I talk about that?
Made the articles all open access so that anybody can access them. There's 3 meta-analyses, then there's 2 commentary articles, and there's 5 total. You can find them on our website, or you can search PubMed for them. They're very straightforward to find. You also can find our database on our website, and this is what it looks like. So each of these rows are a different
study. And so see in here, here's the title, here's the publication data, like where the citation, here's the condition, here's the outcome measure, here's the participant. It just goes on and on and on. And so what you can do is, this is a little filter. And so you filter, like if you want to filter by, the last 10 years, all of those articles. Now I want to filter by, just a specific condition. Now you're getting just that. So you can take a look at articles if you're an educator. It might be good if you're speaking, let's say you teach pathology and you want to talk about fibromyalgia, which articles should I use? You can pull this up and you can actually also see which have the highest quality rating and pull those articles instead. So this, we make this freely available because we want people to actually get into literature. If you want to do this, you don't have to. We do have podcasts if your students or you want to hear more about what we just said. You can have them watch that because we think it's a lot easier than trying to figure out a forest plot for yourself. And so, there's lots of different ways that we've tried to present this information to educators and to students. So
I'd love to say a word about the publication process.
Yeah.
We decided early on that the International Journal of Therapeutic Massage and Bodywork was really not the best venue to publish this information, because while we want massage therapists to access it, we also, our real target market are the general practitioners and the oncologists and the surgeons. So we published in, is it Pain Medicine?
Pain Medicine.
In Pain Medicine, which is not an open access journal. But we paid a special extra fee to make it open access. And it will be open access, the 3 articles plus the commentaries, forever. Oh, it's already out.
It's out.
It's out.
When did it come out?
Last year.
Yeah, last year ago, May, I think, roughly. I mean, it was 3 issues, consecutive issues for the 3 different articles.
So we want to say thank you for having us here. We also want to say thank you to Samuele, of course, because they did the heavy lifting. AMTA funded the foundation to fund this study, so we're very grateful for that. And the panel of experts, anybody who's in the military can't take extra pay to do extra work. All they can take is their salary, but they were very excited and they put in their own time to do this. So we're very thankful for all of them, as well as the massage therapists that helped us with this. So thank you for listening to us today. Are there any final questions? Okay.
Afternoon class.
Yeah,
I saw that.
It's 2 to 4. Oh no.
Yeah, 2 to 4 again.
It's just very short. You can keep the answer short. I understand there's a trend towards saying that people have to publish research that failed, so they can't just cherry pick it because it's really not giving. It's not indicative of the.
Because of meta-analyses. If the studies that failed aren't included, we're only seeing the positive, and it looks like it's really positive, but we're not getting the full picture.
So where is that in the process, the dialogue, just about saying that's going to be a requirement?
Well, nowadays, if you do a clinical trial, you have to register it when you start it. So clinicaltrials.gov has all the clinical trials that are ongoing or completed. If you don't have that registration number, most journals will not let you publish that. And so if you're doing a meta-analysis or a systematic review, you go into clinical trials, you look at how many studies are in there, and then you go to PubMed, how many studies are published. You need to talk to the groups that didn't publish their stuff. What happened? How come you didn't publish it? Was it negative? And so that's how we now get around it. We're trying to prevent that.
Okay, thank you.
Remind me, when the press releases came out, how many hits did it get? I mean, it got a lot, right?
Oh my God.
Was it?
So with each of the 3 meta-analyses that were released, we worked with AMT and Samuele and the foundation to have like group press releases go out. And so when each of these went out, they were able to look at how many hits, meaning how many people actually viewed it or clicked on it. Each one was about 10 million. I know. And it went like all over the place. It was huge. So this really This was a very big deal, and we're just very, very appreciative of the help that AMTA and Samuele gave, because they have the marketing, they were able to help us write it and make it impactful and really push it out there. We're little, we have, 4 staff, and, we use every thin dime, and we do our very best, but to have big organizations help us out, we really appreciate that. And so we're very thankful for the Alliance for having us here so we can talk about these things, and and for the fundraisers so that we can do more of this and really keep impacting the profession. We're not for profit, we just want to help the profession keep moving.